Are you struggling to find a pathology lab that truly understands your needs? Look no further than Bako Diagnostics. With customized services for today's podiatric clinician, Bako Diagnostics continues their commitment to educational initiatives that propel the profession forward. Bako Diagnostics, more than just a pathology lab, they're your professional partner for podiatric pathology and therapeutics, helping podiatric physicians keep America on its feet.
Hello, everyone. Welcome to Dean's Chat, where we discuss all things podiatric medicine. My name is Dr. Jeffrey Jensen. I'm the Dean at the Arizona College of Podiatric Medicine and the host for the Dean's Chat podcast. Once again, I'm joined by my co-host, Dr. Johanna Richey. Hello, Joe.
Hey, Jeff. How you doing?
I'm doing wonderful. I'm recovering from a busy Labor Day weekend.
Good times. We had a lot of restoration moments built into the weekend to spend time with friends and family, both, and it was absolutely lovely.
I think we should make a petition to go to 4-day weeks at the university.
You know, there's a lot to be said for that. I will say though, being in clinic today, now it's like squeezing 5 days of work into 4. So there's pros and cons to both.
Well, we have a wonderful guest today, Joe. Dr. Gary Rothenberg is from Michigan, and we're going to talk about a little bit of transitioning in careers. But first, welcome to Dean's Chat, Gary. We're so glad to have you.
Thanks so much for having me. Appreciate it.
You're welcome. And Gary, we're pretty informal on Dean's Chat, so if it's okay with you, we'll go with Gary and Joe and Jeff.
Absolutely perfect. Love it.
All right. Well, I'd like to give you a little more formal introduction. Dr. Rothenberg is a board certified podiatrist. He's a certified diabetes care and education specialist. He is certified in wound care, and he holds an associate professor appointment within the Endocrinology Division at the University of Michigan School of Medicine in Ann Arbor, Michigan. He's also the director of a 2-year fellowship that is research-based at the University of Michigan, and I'm really looking forward to talking about that more. Lastly, you've made a transition over the last couple of years, and you are currently the Director of Medical Affairs for Podometrics. It is a diabetic foot prevention company, and we're really looking forward to hearing more about that. And I don't mind kicking it off, Joe, right there. Let's talk about Podometrics. What a wonderful technology. I've been reading about it for years. I was so excited, Gary, when I saw that you were taking up the helm in medical affairs. Can you tell us a little bit about Podometrics and your role in the company?
Yeah, well, thanks for that. It's been a really exciting journey. So I'll share with your listeners, especially the younger ones. I was involved with research when I was in Miami with Podometrics, and some seeds were planted back then. It was a really interesting time. They came to me looking for sites for a multi-center trial, which we ended up participating in, where they were looking at innovating the original works that Larry Lavery and Dave Armstrong did with the dermal thermometer, and the really sound science around that technology, that adding temperature monitoring to a good preventive foot strategy would be really useful in helping avoid recidivism with diabetic foot ulcers. So I participated in the clinical trial, got to know the product, got to know the amazing outcomes that we ended up publishing in Diabetes Care in 2017. And then I was a consultant for them for a little bit. And then a couple of years ago, the executive team came to me and said, hey, you know, we're in a place to hire a medical director. You're the guy we want because you did our research. You've been consulting. There's no kind of honeymoon period here anymore. We're already married. Let's take this journey forward. And so Podometrics is really a mission-driven company to end avoidable amputations among people living with diabetes. We know some amputations will occur for various reasons, but the literature will report and show up to 75, 85% of diabetic foot ulcers can be prevented just by doing good strategies. And I hope we can talk about that. But I'm thrilled to be on this journey. I'm frankly, again, probably like your listeners, I'm tired of having conversations after practicing for 25 years with my patients on, okay, Mr. Jones, you have osteomyelitis. Do you want medical management or surgical management? Which route? You know, it's like the lesser of, it's either way is a poor choice with really bad outcomes. So I always say changing destiny. Imagine this world where we wouldn't have to have so many advanced wound care products. And I'm thankful for those, that we have negative pressure and skin substitutes and things like that. But again, if we're not having to treat those wounds, if we could prevent them, that's better for everyone. That's better for our patients. And that's, frankly, it's more cost effective too. So yeah,
Good.
it's a great
My
journey
first
to be.
thought, it is my first thought is it's no surprise to me that you were in demand. That doesn't surprise me at all that they came to you. I remember all the research that we did collaboratively over the years with clinical trials. And so congratulations. That's just a wonderful opportunity. And I do want to talk about it more. I was going to mention, Joe, it's interesting that a lot of our guests that we've had, Gary, recently are delving into more of the technical side of medicine, sometimes as a secondary role, secondary job, or like you, transitioning more. But it's exciting, Joe.
Absolutely.
So let's talk about Podometrics a little bit more, Gary. You know, I know back in the day with Paul Brand, he was always talking about the heating up of the foot and predicting where a wound was going to occur. In fact, he did all those crazy studies on residents, running them through a hospital that we would never get by IRB today.
And tapping his own finger on a desktop, right? Until it became painful.
Absolutely. So your company, Podometrics, has taken temperature gauge management or temperature managements of the foot away from the clinic and to the patient. Is that correct?
Yeah, so I appreciate you bringing up that the works of Paul Brand. 50 years ago, he was identifying the fact that heat precedes complications. Inflammation precedes diabetic foot complications, right? So yes, and then I say Lavery and Armstrong kind of innovated that work, and they tried to use the temp touch, and it's still being used somewhat in clinics around the world, literally. But yeah, their studies, when you look at their 3 RCTs, you can reduce diabetic foot ulcer recidivism by 72% by just adding temperature monitoring. The problem that they found and that we found was that it wasn't a patient-friendly modality, right? So the patients, again, if your listeners are familiar with the technology, so Lavery and Armstrong asked their patients to test their foot temperatures on both feet, 6 individual spots, do the math, and try and look for hot spots or temperature asymmetry of 2.2 degrees Celsius or 4 degrees Fahrenheit temperature differential. And if they noted that, then they should offload and call their provider. So the problem is, as we all know, many of these patients have neuropathy. A clear vast majority of them have retinopathy. They're obese, they have mobility issues. So literally trying to take their own temperatures, and then frankly, think about the usual patients that we're all seeing in clinic, that math to do the asymmetry and self-initiate a treatment, it's too much of a burden for the patients. While the science was crazy sound, it wasn't user-friendly. So Podometrics is very upfront in saying we did not invent temperature monitoring, but we did innovate it. So it's now in a very patient-friendly model. It literally is a bath mat. It looks like a bath mat. It's the size of a bath mat. There's 1,000 temperature sensors embedded in the mat. The patients step on it. It takes 20 seconds a day. It connects to the closest cellular tower, and it doesn't require Wi-Fi. It doesn't require an app or anything like that. And then we have over 50 clinical nurses who are monitoring, and we do use AI, machine learning, and models to predict, and using that same Lavery Armstrong model and predictive protocol, when there is asymmetry noted in 2 consecutive scans of that temperature asymmetry, then our nurses call the patients. That prompts a conversation. And it's amazing the things that we hear. And I'm privileged as the medical director to listen to some of these, mostly for quality assurance purposes. But I listen to some of the calls, and the things that the patients say, they're very unaware. We lead off with, "Hey, Mr. Jones, how are you doing today?" Not, "Hey, the mat you're stepping on, your foot's lighting up like a Christmas tree." No, we know there must be something going on in this comorbid patient with advanced pathologies, neuropathy, diabetes distress, retinopathy, all those, again, things that we mentioned, that must be tripping and triggering some event. So it's really then that we gain information from the patient, initiate offloading protocols, simple, inexpensive things every day. Make sure your glycemic control is as good as it can be. So what we've learned in working with providers and the SmartMap program is that they really want 3 important things in between their own clinical visits through a remote monitoring program like Podometrics. They want to know things that are actionable. They want to know things that are pertinent, and they want to be aware of things that they are unaware of, things that are occurring in between their usual preventive visits, at least among this high-risk patient population with diabetes.
That makes sense. I just think it's fabulous that there can be connections to the patient without the patient having to go through all the motions. Stepping on a mat is easy to do, and we got to make it easy on patients.
That's right. They have so much, especially this patient population with advanced diabetes. And again, the smart mat is not right for every person with diabetes. It really is a targeted solution because recidivism rates for diabetic foot ulcers are so significant. So we know history repeats itself, right? If you've demonstrated that you will ulcerate because of neuropathy and deformity and all of that stuff, then you have a very high risk of reulceration. So the solution is really for high-risk patients who've already had amputations, DFUs, Charcot feet, dialysis patients, the high-risk patient population.
That makes sense.
I think that that's also something that's such a unique opportunity in this space right now, as medicine has continued to shift into more leveraging technology to help us. And I love those three things that you had highlighted, because again, as a provider, those are the things that are useful to me to know is, when do I need to know about this for my patient versus just randomly checking off all of these metrics? Like, that's exhaustive. Nobody wants to do that. But interventions that have real opportunity to save parts of someone, such as preventing amputation, even minor amputation, is huge. And then in that space, when we can show that that technology value and benefit, it can start to expand into other areas. So for now, we have these high-risk patients that are significantly high risk. And hopefully one day we can transition that to patients that are at moderate risk to prevent them from ever becoming in that high-risk group. Because once you start having foot deformity, whether that's from Charcot, amputation, just general foot deformity at baseline, that's when you start to tip into these higher groups. So all the wearable tech now that people have with glucose monitoring and heart rate monitoring, like so many different ventures that people are looking into for med tech, I could completely see the transition here for our patients with diabetes. At some point, these can become insoles and they can start getting immediate feedback. And how amazing would that be to help someone not even get to the point of ulceration? And I know those are some really big leaps that I'm making, but in terms of the significance of this kind of work, preventative care could save millions of dollars and certainly hundreds of thousands of lives that right now we're just not able to find the best solutions for. So my next question for you, Gary, is, in this tech space, as you have made that transition from clinician to medical director, what have been some of the challenges that you have found navigating that transition?
Yeah, so appreciate that for sure. So I think the biggest challenge is getting in front of people, getting them to buy into this. We've done, frankly, a poor job. The skin substitute space, is explosive. There are Me Too products coming out all the time. There's not a focus on prevention. There's a focus on treatment of these diabetic foot ulcers. It's probably, not to be too political, but a reflection of our healthcare system. It's really reactive. It's not proactive. So I think where you're going with the question is, we need people to buy into prevention, that it is the right thing to do, that it is cost effective as well. Now, I understand all solutions need a form of payment too, right? And nothing is free in healthcare, and I understand that very much. But what we're finding, and when I talk to people, they see this targeted solution as amazing, right? But unfortunately, many health plans are more concerned about what they're paying on the front end and not what they're saving on the back end.
Yeah.
And that's unfortunate. So I think the biggest issues are reimbursement, and sources of frustration are around reimbursement, and they're around access and making sure that those patients who really need them and can benefit from them, and traditionally that unfortunately is our underrepresented minority populations, which typically, or rural patients who don't live in the urban areas. So access to healthcare is still one of the biggest issues in the US healthcare system, I think. And I'm optimistic, I'm going to turn this around a little. I'm optimistic that remote patient monitoring devices, and I love to think of the smart mat as the CGM of the foot, right? But I love to think that remote patient monitoring, telemedicine, telehealth technology can really help be a bridge for patients who traditionally are underrepresented.
I love that, Carrie. You know, I have this vision of an accountable care organization that's in control of 1 million lives, for lack of a better round number. And X amount of those patients have diabetes, X amount of those patients have had a wound in the past. It'd be very easy to target those patients. But I also have a vision of getting into wound care centers. And when they come out of a total contact cast or whatever device they've healed in, boom, they're into appropriate shoes and they get a mat to go forward.
Yep.
Is
It's
that the vision?
plan, a
Oh, yeah.
comprehensive plan. Or go into dialysis centers,
Oh,
right?
yes.
Like, what is the cross, activity between renal disease and diabetic foot ulcers? I guarantee you, you pull back the sheets in dialysis centers, you are going to find a fair number of diabetic foot ulcers. And look in the hospital, at patients admitted with diabetic foot infections, what percentage of them have kidney disease? So we know the patient population. And I agree, we need to be a little bit more integrated, a little bit more comprehensive with our preventive strategies.
And even in regards to amputations, right? So patients that unfortunately have progressed to the point that, as you said, there are 2 options that we're kind of stuck with. And sometimes we don't even have 2 options. It's like, look, we really actually have to take the part off. And so as we start looking at the demographics of who's at risk of even having their amputations fail, renal disease is an independent predictor for a more proximal level of amputation. So again, if we can identify these true high yield patient populations and hopefully be able to show the value to make the argument for the upfront investment for preventative care, then it makes it more translatable and hopefully more equitable for conditions that aren't just that. But we have to start somewhere. So I commend you. I think that this is such an exciting field. I think slowly as a community, medicine will start to pay a little more attention to preventative care. I think the work that Dr. Armstrong and Dr. Laver have been doing in terms of demonstrating the cost of what's happening right now will hopefully help support the initiative that preventative care saves significant dollars to the healthcare system. But time will tell what the third parties do with that.
That's right. Yes, agree.
I have a question for you. If I'm a doc anywhere around the country and I have a patient who I think is high risk, they're healed, but they're high risk, neuropathy, deformity, they're on their feet a lot. How would they get a hold of one of these mats? What would you recommend to that doctor?
Yeah. So the website is a great place to start, the company's website, which is podometrics.com. And there's a lot of great information for providers, for patients on that website. We do have contracts with several health plans around the country. So it is possible that a patient could benefit from the technology. Our largest experience, as I mentioned, I came from the VA system. The smart mat is available. In fact, it is promoted for what they call PAVE 3, prevention of amputation smart mat. So I always say, I practiced in the VA for 11 years. It's such actually a progressive health system in terms of getting veterans what they need, in terms of doing research and embracing technology early, which I love. So and veterans are able to get the mat, and private pay patients may as well, but I would start with the website. Appreciate that.
That's fantastic. Well, you certainly don't get into a position of a medical director unless you've got a large history of patient care and research behind you. I was thinking we'd shift gears a little bit and talk about your career. Maybe, Joe, maybe a good thing to start with is the fellowship. But maybe it'd be a good time for me to give a little shout out to our sponsor.
Absolutely. Let's hear from you.
All right. So I want to do a quick shout out to our sponsor, Bako Diagnostics. Gary, I'm sure you're familiar with Bako. We all know that early detection is the most important determination in improving outcomes for our patients. Bako Diagnostics remains committed to supporting you in your role as the first line of defense in diagnosing lower extremity pathologies. Bako Diagnostics, helping podiatric physicians keep America on its feet. Gary, Bako has been such a phenomenal company for our
Great
entire
company.
profession for so long. So um,
I love how
talk
they
about
support residents and students and all of us as podiatrists. Great
speaking,
company.
speaking of fellowships, they have a 2-week fellowship for residents also. So with
They
that
do.
segue, Joe, you want to kick it off talking about the fellowship?
Yeah, so you've had an outstanding opportunity at this level of your career to have taught all levels of training, from students to residents in multiple different health systems, and now fellows. What are your thoughts about the evolution of training, and how do you kind of look at what you focus on at each of those stages of training?
Yeah. So I have been very fortunate. My career has spanned student education when I was with Dr. Jensen, with Jeff at Barry, and I'm very fortunate to be adjunct faculty at many of the schools. And in fact, next week I'm going down to the Lower Rio Grande Valley to do some lectures down there at UTRGV. It's so exciting to be on a campus and to really inspire the next generation of podiatrists. So the students, I just find them as sponges, and it's amazing. They just want to, absorb everything, learn everything. They're eager, they're exciting. So that's been really, really neat. I do think there's a transition from student to resident, because as a student, obviously you're paying for your education. I always try to impress upon residents, there is no other time in your life you will get paid to learn. Like, what an amazing opportunity. So I really never wanted residents to think of residency as a job. It was really more than that, much more than that. It's preparation for your entire career, right? I encourage the residents that I was responsible for and that I interact with to take advantage of every opportunity, every case. Go to it, whether you're on or you're not, if you can. I understand we all have to have a life outside of work too, but those are preparation for your career, and it's just an exciting time to get paid to learn. Fellows, I think, are a little bit different. We don't have to do fellowships. I encourage people who have a particular interest in something and maybe they weren't exposed to it as completely as they wanted to be in their residency program. I know, again, I ran a residency program in a VA. We had such limited, just squeaking by enough podopeds to meet the requirements. It was a VA. We didn't treat kids. So, of course, if you have a passion or an interest in treating kids, do a fellowship in Podiatrics. Ours here at the University of Michigan, our fellowship is really research-based. I know a lot of residency programs, they have a research requirement, but very few allow residents dedicated research time. Maybe they do a poster, maybe they do a case report. All those are great and wonderful, but people, I think, can be talented and have a strong interest in research, and that takes time and that takes mentorship. So here at the University of Michigan, we have such an amazing infrastructure for a wonderful research-based fellowship where we focus on lower extremity complication prevention, but we also are really in the mindset of producing the next generation of academic podiatrists. So those who want to teach, those who want to, again, do research, contribute to our profession. And I always say there's no better marketing than publication. So you will become notarized and, and noted and being seek after for lectures and podium talks and all of that when you do good research. So it's a great contribution. So I do caution fellows, though, you tend to practice what you do last, right? So it tends to niche your practice maybe just a little bit. And I do acknowledge and recognize taking 2 years beyond residency. That's a big commitment. Most fellowships are 1 year, but we just felt very strongly that by the time you think of an idea and submit an IRB and it's a randomized clinical trial, you can't do that in a year. You just can't. So we've been very fortunate to have great fellows, many of whom we've kept as faculty members because they're that wonderful that we want them to be colleagues. But we're also proud of the ones that are across the country doing great work as well.
And I'd love to piggyback on that, if you don't mind, Jeff.
Sure.
I had seen on your LinkedIn, your recent poster presentation that you had put out with the Native Health. And it's, I think, a nice little segue between the two conversations we were just having in terms of preventative care for certain marginalized communities and the research kind of arm of the fellowship. Can you talk a little bit, you don't have to give the full details of it, but can you talk a little bit about that project?
Yeah. Well, we do try and practice what we preach, because I do believe that all trainees, kind of look to us like parents, right, as their attendings. So I do try and get out there and do posters because I think they're valuable. I do try and publish as much as I can. We do that with our fellows, and the faculty has projects on their own as well. I'm very involved with, was the result of a survey study that we did with Podometrics last fall, where we really were exploring kind of the experience of the healthcare system, specifically among Native Americans living with diabetes. What were their thoughts and their experiences and their roadblocks? And specifically, we asked questions around technology, like, do they already use technology? Are they opposed to using technology? And the survey results were really, really fascinating. First of all, we know Native Americans of all races have the highest incidence of diabetes at 14.5%. And unfortunately, there's such strong genetic components. And we also know, of course, that they're subject to neuropathy, not only from diabetes, but also from the alcoholic pandemic, issues that run rampant within the Native American population. So they have this double whammy. But unfortunately, there's a lot of social issues that are affecting Native Americans today: access to healthcare, living in rural areas, the diet and nutrition. And the interesting part was that Native Americans really, they want to use technology. They believe it would help them be more adherent with medication usage. Many of them live with chronic medical diseases beyond diabetes, including mental health issues, again, alcoholism, heart disease, the usual culprits that we see. But the really scary part of the Native American population is, and I've talked to colleagues who practice in the Southwest. Janet Simon was a partner in this survey project out of Albuquerque. She's telling me that she and her colleagues have clinics full of 20 and 30-year-olds with diabetic foot ulcers. And I've never seen that in my practice. Thank goodness. I would be heartbroken if a 20-year-old came into my clinic with a diabetic foot ulcer, and by 40, they're, on dialysis and have amputations. So we're really seeing this problem occur earlier and more significantly in the Native American population. So it's a particular passion now of mine, because I think they're so deserving, and we really need to bend the curve on these statistics, especially among marginalized communities and specifically the Native Americans.
That's great work, and it validates everything that you're doing at Podometrics.
Yeah, we're trying. We're definitely trying.
Right.
It goes back. I know you're a huge fan, and I listened to your Dean's Chat with Larry Harkless, who obviously is my greatest mentor, and was my residency director. And it all comes back, as he used to tell us, and I know he probably has shared with you a million times, park at the bedside. Ask the patient, what are their issues? What are their hopes, their dreams, and their fears? And through that, you hear the most amazing things. And we talk about social determinants of health. I was really fortunate. Larry Harkless taught us about that 25 years ago. We didn't call it social determinants of health. He just said, you need to find out what are your patient's hopes, dreams, and fears, and what's stopping them from doing the things that we all know are the right things to do. But the Native Americans in particular, they've been talking about social determinants of health for years and years. They know everything is connected to everything. If you don't have transportation because you live in a rural area, your outcomes are going to be affected. So we have to, again, get a better handle on, and I'm proud, and I think we're teaching that somewhat more these days, around SDOH, and recognizing and having conversations, but it's a hard conversation to have sometimes with patients.
It is. And I thought it'd be a good story to tell you. We're in our second year of submissions with Senator Sinema from Arizona for some federal funds to look at the highest risk diabetic feet, identify them, and do everything we can to prevent their recurrence, which goes back to Armstrong's article in 2017. The perfect recidivism answer is if you can do this, 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 and this, but the Podometrics mat wasn't in that. So I think that we may be calling you there, Gary, and incorporate that into the study.
We'd love to help. Yes, absolutely. Absolutely.
All right, very good. So you went to Ohio College.
I did.
You went to the University of Texas.
Yes.
Larry Harkless was a mentor. What are some other mentors you met down there?
Yeah, so I was in San Antonio, what I call the heyday, right? I mean, it was the late 1990s. We were doing, so Larry Lavery, Dave Armstrong, Kathy Satterfield, Harkless, Orrin Burnett at the VA. These were all my teachers and mentors. And the other thing is that my co-residents became mentors. People like Alex Rizelman and Suad Hadi and Javier LaFontaine. And, we were really inspired, I think, by the team, by the work that was being done. There was no lack of patience, that's for sure. But there was something very inspiring about being in that group and participating in some of the original clinical trials on skin substitutes and negative pressure wound therapy. I remember platelet-derived growth factor as a resident, you had to go in every 12 hours. So as residents, we were like, well, shoot, what's the best schedule? We got to go and dress this. Should it be 8 a.m. and 8 p.m.? Should it be 6 a.m., 6 p.m.? Like, how are we going to arrange that? But it was, again, very inspiring. We were doing negative pressure wound therapy. We were doing skin substitutes, all these great, again, I'm sure it's part of the foundation for my passion and inspiration to then teach and do research and make a difference in this patient population. So very proud of my training, super fortunate that it has, as Dr. Harkless would tell us, it'll open the door for you, training at a big public teaching institution and coming from UT, but it's what you do when you get through the door that will make the difference.
Absolutely. And they're putting the band back together a little bit down in UT San Antonio. Larry Lavery's going back there.
That's what I hear.
So Joe, maybe we should get a little podcast together with Larry and David Armstrong and Gary and Alex. Get a few of your colleagues from back in the day together. That'd be a good little
have a mastermind session.
Yeah. Joe and I can sit back and listen. You guys just go for it.
We'll just throw a question out like every 20 minutes and be like, go.
Absolutely.
It would work. It would be exciting.
Well, Gary, we are so thankful that you could make time in your busy schedule to join us. We will put in the show notes all the information about Podometrics. I wish you the most success in your new position. Congratulations.
Thank you. So appreciative. It's great discussions.
You're always welcome on Dean's Chat. And to all of our listeners out there on Spotify or Apple Podcast, if you can put a note in talking about the podcast and also give us a 5-star rating, we'd be very thankful. And of course, if you're watching on YouTube, we'd love for you to become a subscriber. And Gary, we've got one of these Dean's Chat cups we're sending your way.
Hey, I'm looking forward to it.
Yep, you're going to need it on those early mornings with the fellows and grilling them, no doubt.
That's right.
Train them up, man. All right. Well, until next episode, thanks again, Gary, and thanks, Joe. Cheers, everybody.